Welcome back, everybody. We're going to continue our discussion on elimination, focusing on urinary calculi. Our objectives of this session, we're going to talk about urinary calculi and how it relates to elimination. We will discuss pathoetiology, risk factors, prevention, always discussing manifestations, diagnostics, and therapies, and then apply the nursing process to our care. Urinary calculi is sometimes called kidney stones. It's the development of one or more crystals, and they range in size from very small to large. They can large anywhere in the urinary tract, and they may cause obstruction and or kidney damage. They can cause excruciating pain, and they're most common cause of upper urinary tract obstructions. The word lithiasis is actually stone formation, and nephrolithiasis, if you hear that, that's stones that form in the kidney. And urolithiasis are stones that form elsewhere in the urinary tract. Now, when we're looking at patho, there's many factors that contribute to urolithiasis. Sometimes there's stimulation for formation of stones, and this can be meals high in insoluble salt, low fluid intake. Stones are also affected by the acidity or alkalinity of urine or the presence or absence of calculus inhibiting compounds. Now, stones can be a variety. 75 to 80% of kidney stones are composed of calcium oxalate or calcium phosphorus. So we're going to focus on that starred one right there. There are other stones, uric acid stones. These develop when concentration of uric acid is in the urine is high. Uric stones are more common in men and are associated with a condition called gout. Struvite calculi are associated with UTIs. They can become very large, and they're often called staghorn calculi because of their shape. The cystine stones, these are rare and they are caused or associated with genetic defects. Now, just going back to those calcium oxalate and phosphate ones, those are associated with high concentrations of calcium in the blood or urine. Some risk factors, or let's back up, some etiology that we want to talk about is that most stones are formed in the renal pelvis and they're composed mostly of calcium salts. The incidence of this condition varies in the United States by the region. Males are affected 1 to 2 times more often than females, and it's more common in Caucasians than African Americans. This also mostly affects young or middle adulthood age individuals. When we're looking at risk factors, most stones are idiopathic, which means they have no known cause. The greatest risk factor is a prior personal or family history of urinary calculi. Some other things that are going to come into play for risk factors is dehydration. That's going to cause the urine to become concentrated. Immobility, excess dietary intake of calcium, oxalate, or proteins can contribute. Other medical conditions like gout, hyperparathyroidism, urinary stasis, or repeated infections, as well as other factors could be loss of calcium from bones. We always do want to think prevention, and one of the things that we're going to focus on is making sure that our clients have adequate fluid intake, and that's going to help prevent future stones. All right, so just a little graphic here that I found that maybe will help you remember some manifestations that we're going to talk about. The symptoms that a client's going to have can vary by the size and location of where the stone is. Calculi that affect maybe like general outside of kidneys and in the pelvis region, they may have few or no symptoms. But if the stone gradually or partially obstructs urinary flow, that may lead to a dull, aching flank pain. Calculi in the bladder will manifest as dull suprapubic pain with exercise or after voiding, and you may see gross hematuria as a sign. If you've got stones that are in the ureter, this can cause renal colic, and it's an acute severe flank pain on the affected side that may radiate to the suprapubic region, groin, or external genitals. This also has association with it with nausea, vomiting, pallor, and cool, clammy skin. Urinary tract infections may also accompany urinary calculi at any level. So this could put our clients at risk for greater infectious processes. So there are some complications with urinary calculi or any type of stone. One of them is that they could cause an obstruction. Now, this could come on gradually, and this may not show a lot of symptoms. However, if it's a sudden obstruction, you're going to see severe manifestations in your patients. This can ultimately lead to renal failure if the obstruction, causes the urine backup flow through the bladder to the kidneys, and then we can cause a whole host of problems. One other complication that you may be aware of is hydronephrosis. This is accumulation of urine in the renal pelvis resulting from obstruction. The kidneys are going to continue to produce urine, but then this backup is going to have increased pressure and distension of the ureter or hydroureter. Chronic hydronephrosis can develop slowly and manifest with few symptoms. But if it's acute hydronephrosis, you're going to see colicky pain on the affected side that radiates into the groin. You may have a palpable mass in the flank region, hematuria, urinary tract infection, and GI symptoms may be present. Infection could be a huge complication, and this is because of the urinary stasis associated with a obstruction, partial or complete. Again, this increases the risk of UTIs, and they can be upper or lower. When we're considering collaboration, we really want to think, what can we do? So we want to make sure we relieve acute symptoms, manage pain, increase fluids, destroy or remove the stone. So there's going to be some diagnostics and surgical pieces to come into play. We want to make sure we teach and educate to prevent further stone formation. And asymptomatic stones, we want to treat those very conservatively. All right, so you're going to see a lot of diagnostics for clients that have urinary calculi. We do want to focus on the starred ones, but I do want to talk a little bit about some of the things that we have here on this list. Of course, we want to do UA or urinalysis, and we're looking for blood in the urine, or we're looking for crystals in the urine, or we're looking for increased white blood cells, which may be indicative of an infection. We want to look at the chemical analysis of a stone that gets passed in the urine, because we want to know what type it is, so we know how to teach our patients to prevent them from having them in the future. We want to look at urine calcium, uric acid, and oxalate levels. Again, this is going to determine the stone type and what may be causing it. We want to look at serum calcium, phosphorus, and uric acid levels, because that's going to tell us what may be contributing to the stone formation. A big one is a kidney, ureter, and bladder, also known as a KUB, and that's what the graphic is on your right-hand side. This is where you can actually visually see the stones. We may do a renal ultrasound, and that's going to look for stones or hydronephrosis. Your clients may have a CT scan, and this may show calculi, ureter obstruction, or other renal disorders. Sometimes patients will have what's called an intravenous pylography or IVP. This is going to look at the kidney, ureter, and bladders, and they're going to use a contrast medium. And it's used when a KUB, a renal ultrasound, and a CT fail to demonstrate calculi. And cystoscopy we talked about in our last presentation. So there are a few surgical interventions that can be done for clients with urinary calculi. The most common lithotripsy, or an ESWL, this is where the stones are going to do shock waves, and they're going to fragment those stones to very small so that they can pass in the urinary tract and go out with the urine flow. The other ones that are listed are very rare, so we're going to focus on care of the client for an ESWL. All right, so here's our farm and non-farm slide. You guys might be happy with this one. I don't have any meds listed. However, when we do treat clients with kidney stones or stones, analgesia is common to be put on board, especially opioids like morphine, which you are familiar with. Again, we want to keep, for acute episodes, we want to keep our clients pain-free if we can and hydrated. So we want to make sure they're getting probably at least 2,500 milliliters a day, unless there's a condition that contraindicates that, for example, like CHF. There are some meds that can be used to prevent stone formation. So, for example, for calcium calculi, a lot of times they'll order thiazide diuretics, and that will help prevent stone formation. Non-pharmacologically, again, small kidney stones, we're going to treat conservatively. We're going to increase their fluid intake. We're going to increase activity. And then we want to do diet teaching to prevent stone recurrence. So it's very important for you to look at, especially calcium phosphate and calcium oxalate stones, what diet modifications or what do you need to teach your patient to avoid or reduce so that doesn't potentiate stone formation. So ultimately, what we want to do for our clients is to make sure that we provide them comfort if they're an acute renal colic. We always want to assist with any diagnostics or lab procedures. We want to make sure that they have adequate intake and urinary output and a lot of teaching to prevent stone formation. Because remember, if they have a personal or family history of it, they're more prone to getting them. When we're thinking assessment, again, you're going to do your total assessment. You know now you're looking for pain, any grimacing, moaning, guarding of that flank area, pacing, rocking, any other symptoms. You want to ask, what's your family history? What's your personal history? Always look at a client's general appearance and then look at any tenderness, especially in those flank, groin, abdominal areas. Truly assess the urine because we're looking for any hematuria, and then anything the kidney, anything the client may say that's in that kidney area. Some common nursing diagnostic statements that are going to help drive your plan of care. You guessed it, acute pain, probably right there on the top of the list as a priority. And another top lister is going to be impaired urinary elimination. They may also have anxiety, deficit knowledge may be added to that list as well. And let's not always forget risk for, so risk for infection, because if there's an obstruction or a blockage, a client is then at risk for infection, and we need to be astute to look for that. We do want to have goals in our plan for our patients. So some of the goals that we're thinking about and then kind of diving into implementing too is, we got to think analgesia, pain control, maintaining urine output. That's equivalent to the intake. Again, 2,500 milliliters a day unless contraindicated. We don't want our clients to have any signs of infection or signs of urinary obstruction. And hopefully no anxiety. When we're thinking of, well, how can we deal with the pain? Let's think about positioning our patient in positioning our patient in a comfortable position. We want to use moist heat, any relaxation techniques that work for them, and to include guided imagery. Always assess pain regularly, and if your client has a surgical procedure and potentially a catheter, you want to make sure that you assess the patency of that catheter and do measures to prevent infection. Always, always, always monitor intake and output. They're going to be on strict I's and O's. Look at that renal panel to make sure that the kidneys are still functioning appropriately. We want to make sure that we teach our clients and in a manner that works for them, that is at their level. If a client is passing the stone normally or has had lithotripsy and is passing small fragments of stones, we want to make sure that we teach them to collect their urine in a hat and strain and save any stones. We don't want those to go in the trash or in the toilet because we want to analyze those stones to see what kind they are. And then always report to the physician if there's any changes and manifestations or changes in the urine. We want to make sure that We evaluate whether our clients have met their outcomes or their goals. And, are we able to manage their pain? Are they able to go and perform ADLs? Are they free from infection? Are they on the right diet so that they don't get stones in the future? And I think I said this about 3 times. We want to make sure they have adequate fluid intake. That's just going to help prevent stones all around as well. If you have any questions about this presentation, please do not hesitate to use the Prep for Exam 3 discussion forum located in your Blackboard course.